So let's just start by taking a step back and review what happens during a normal menstrual cycle.
Yeah, so for many of us, this might not be something we've thought about since medical school, and you may have put it out of your brain the same way I've put many other things out of my brain. But when we think about the menstrual cycle, the job of the female reproductive system, and, so that's anybody with ovaries and a uterus, is to try to get us pregnant. Mother Nature wants us to procreate and pass on our genes. And so the menstrual cycle is this really intricate pattern and interplay of a whole bunch of different hormones that are coming from the hypothalamus, the pituitary, and then the ovaries, and they are sending messages to the uterus. And what those hormones are doing are telling your ovary to ovulate or release an egg, and then simultaneously telling the lining of the uterus, the endometrium, to build up and then shed. And the shedding happens if the person who ovulates does not get pregnant. So if that egg is not fertilized by sperm. And so classically, we time the menstrual cycle by the first day of bleeding. So we'll call that cycle day 1. Cycle day 1 through maybe 5 to 7 would be the period itself, the menstrual period, or the time of the days of bleeding. And then the bleeding stops. The egg is released, so ovulation happens generally around day 12 to 14. So that's when you would expect fertilization to occur if it's going to. And then if fertilization doesn't occur, then usually around day 27, 28, the shedding of that endometrial lining happens. And so that would be day 1 of your next cycle. And so that's the menstrual cycle, the normal menstrual cycle in a nutshell.
Paul, you remember all that, right?
Yeah, absolutely. And I was actually going to graph out for you guys all the different phases of the hormones, if that was going to be helpful for you. But we can.
I'm sure you remember the chart where there's the FSH or the progesterone and the LH.
Things are spiking. Yep. Yeah, no, I got it. But I will, and this is where I reveal that I'm a dumb guy. I do find the nomenclature around abnormal bleeding kind of bewildering, like the menorrhagia, metrorrhagia, menometrorrhagia, and dysfunctional uterine bleeding and abnormal uterine bleeding. Can you sort of talk us through the accepted nomenclature for what we're describing in this case and sort of how to talk about it so we don't sound as confused as I am sometimes?
So there used to be a lot of those terms that people would use, the ones that you mentioned. Maybe around 2011 or so, the International Federation of Gynecology and Obstetrics, which is abbreviated FIGO, the FIGO organization decided to all come together and agree on a standard nomenclature that's all based on abnormal uterine bleeding, or AUB. So we no longer use DUB or dysfunctional uterine bleeding. I never use metrorrhagia or menometrorrhagia. I will sometimes still say menorrhagia, which specifically just means heavy periods, although even there, the accepted terminology is really just heavy menstrual bleeding. So you have heavy menstrual bleeding and then AUB. And then within the overarching category of AUB, or abnormal uterine bleeding, it's broken up into 2 categories and it's often referred to as the PALM-COEIN nomenclature. So on the sort of when I draw this out for my students, I literally draw, I've got PALM-COEIN across the top, and down the left, I write PALM. And those are the 4 structural causes of abnormal uterine bleeding. So P is for polyps, A is for adenomyosis, L is for leiomyoma, which is fibroids, and then M is malignancy or pre-malignancy or hyperplasia. And then down the right side of your table, you'll have COIN, although it's not spelled correctly. It's COEIN, and these are non-structural causes. So C is coagulopathy. You've got things like von Willebrand's disease. O is ovulatory dysfunction, so things like PCOS. I is iatrogenic, which would be, any numbers of medications that we give to people that cause bleeding. So, patients who are on therapeutic anticoagulation, people who are on hormonal types of contraceptives that are then interfering with the menstrual cycle, and things like that. And then E is endometrial. Endometrial causes of abnormal bleeding would be things like low-lying endometrial infections, or even, frankly, cervical infections if you're not sure where the bleeding's coming from. So like a low-lying endometritis, chronic endometritis would be an example of an E. And then N, not otherwise specified. So all those other things that you can't figure out.
Really crammed in the acronym there, Paul.
Yeah, all of it, PALM-COEIN. And so when I write my notes, for instance, like I'll write the patient has AUB-L, if they have fibroids. And so it's really helpful when you're talking to people and when you're, working this out in your head to organize it in those ways. And people can have multiple causes too.
I wanted to ask if there's anything else about the history, because basically you're giving us the differential diagnosis there with those categories. Mm-hmm. What do you listen for in the history that makes you start to key in on one or the other as far as your differential?
In terms of differential, I think a lot about the timing. So for instance, this patient, I know we're saying the past 2 cycles were only 21 days apart. So first of all, I want to make sure that the patient is measuring that from the first day of bleeding till the first day of the next bleed. Sometimes you'll have patients measuring from the last day of one bleeding episode until the first day of the next bleeding episode. Mm-hmm. So that's a artificially short count. So I want to make sure the patient's counting correctly from day 1 to day 1. What were the periods like before that? I don't necessarily need like the last 12 months of dates of somebody's periods, but nowadays many people are tracking them on apps and their phone calendars, and so they often can tell me all the days in the last year they've been bleeding. I also think about whether the patient, presumably this patient based on the case hasn't skipped any cycles, but have there been any months where they don't get a bleed? And then also importantly, has there been any intermenstrual bleeding? So any spotting between periods, any other unexpected bleeding, and things like that. And then in terms of other history, because as we know from medical school, the answer is always you want to know more history. I want to know how she's preventing pregnancy.
Okay.
And how is she preventing pregnancy? And, what are her plans for pregnancy? And it's, in my day, it's not fair to assume that somebody at age 46 is not planning any more pregnancy. So I always ask.